Hello, and thank you for joining us for TGH Ask an Expert, a live Q&A series. I am your moderator, Karen Loftus, joined by Dr. Siviero Agazzi, Professor and Vice Chairman of Neurosurgery and the Director of the Fellowship Program in Skull-Base and Cerebrovascular Neurosurgery, and Dr. Marla Sevilla Alcina, Co-Director of the Pituitary Program and Associate Professor of Medicine. Thank you so much, both of you, for being here today.
Thanks for having me.
Happy to be here.
A few housekeeping notes, as we always have before these. If you have any questions as we go along, place them in the comments section, whether that's on YouTube or Facebook, whichever platform you're watching. We will take some live questions. We're going to get to as many of those as we can as time allows. Plus, we had some really good pre-submitted questions that we're going to get to as well to drive the discussion. A reminder, yes, Dr. Agazzi and Dr. Sevilla are medical experts, but please always consult your primary care provider for individualized medical advice. Okay, before we get started on the actual topic, let's get to know our experts beyond their titles that I read so we can understand their roles in this space. Dr. Sevilla, can you share where you come into play in the diagnosis and treatment of pituitary adenomas?
Absolutely. When something goes wrong with the pituitary gland, some patients may experience symptoms like fatigue, weight changes, headaches, vision changes, in females, irregular periods, fertility problems, or abnormal hormone levels. As an endocrinologist specializing in pituitary disorders, we are responsible for evaluating symptoms, ordering hormone tests to confirm the diagnosis, and helping with decisions about the next treatment. If needed, we provide hormone replacement and medical treatment plans. So this means that we carefully adjust hormone medications, monitor lab results, and make sure that each patient's treatment keeps their hormone levels balanced and their symptoms under control.
Okay, thank you so much. And Dr. Agazzi, can you tell us what your part is in a patient's journey and your specific role?
Well, I am a surgeon, and my role comes whenever we have to either remove the adenoma to relieve pressure on the optic nerves or to relieve, for example, an excess of hormones, or also when we have to radiate the adenoma either instead of the surgery or after the surgery. That's when I come into play and I plan these treatments and I carry out this treatment for our patients after a consultation with Dr. Sevilla and the rest of the team.
Okay, thank you for explaining how the care team pieces work together. And we, of course, appreciate you both being here to share your unique perspectives on this topic. So let's get to that topic. Dr. Sevilla, can you tell us what the pituitary gland is and what a pituitary adenoma is?
Of course. As you can see in the image, the pituitary gland is a tiny pea-sized gland at the base of our brain, often called the master gland. Why? Because it controls many hormones that affect our bodies every day. It makes growth hormone for growth and metabolism, prolactin for milk production, ACTH to signal cortisol release, TSH to regulate our thyroid, LH and FSH for reproduction. And then in the posterior pituitary gland, it stores two hormones, ADH, which helps regulate water balance, and oxytocin, which is released during labor, breastfeeding, and also it has a role in social and behavioral functions. So even though the pituitary is a very small gland, it has a huge role in keeping our hormones balanced, which is why pituitary problems can affect growth, metabolism, fertility, and also overall health.
Thank you so much. I think that the graphic really helps and just sort of sets the table for the discussion we're about to have. This topic drew a lot of interest. We had several pre-submitted questions asking us about pituitary adenoma. So let's get started with the first one that we have. The person asks, how do I know if I have a pituitary adenoma? Dr. Agazzi.
Well, it's an excellent question. I'm going to ask them to bring up the next slide because in pituitary adenoma, really size matters. Okay, let's focus on the two bottom pictures that you have here that is labeled patient B. Dr. Sevilla told you that the pituitary gland is a very, very small gland sitting at the bottom of the brain. What you see there is that little white spot that is in the middle of the screen. Now, if you pay attention, you squint a little bit, you see that in that white spot, there is a very small dark area, almost like a pea size. That is about a 4 millimeter tiny pituitary adenoma. It is tiny, you need to really squint, you have to have high definition screens to find them. Now, a tumor of that size can either be found by accident. So you have a headache, you get an MRI, and they found a small pituitary adenoma. And if that pituitary adenoma is quiet, is not secreting any hormones, we just do nothing about it, and you would have never known that you had it unless the MRI was completed. Now, this very tiny pituitary adenoma can also secrete hormones. Now, if they secrete hormones, they can be tiny, but they can cause big problems. And we're going to talk a little bit later on about the problem of Cushing's disease, about acromegaly disease. Those are all significant presentation of a very tiny pituitary adenoma. Now, look at the top two pictures that are labeled patient A. Size matters. This is a patient that came to our hospital over the weekend. He complained that he could not see anymore. He was going blind. He had a tunnel vision. He lost the vision, the peripheral vision. Well, that big tumor is started as a small tumor in the gland, and now you cannot even see the gland anymore because it's all completely replaced by that big tumor. Now, if you have a big adenoma, we call those macroadenoma. The way you know that you have it is because you lose vision. Not any vision that can be fixed by glass or anything like that. It's this very specific type of vision loss, which is called the peripheral vision, and your ophthalmologist or optometrist will be able to detect that when you have a vision test. So that's how you know that you have an adenoma.
Thank you so much. And we're going to keep going on that topic there. You just mentioned the micro, macro adenomas. How do those differ in terms of treatment and long-term outlook, Dr. Agazzi?
Well, so whenever the tumor is big, you need to remove it because you need to relieve the pressure on the brain, on the optic nerve, so that it stops causing this trouble. And then you have to follow it to make sure it does not grow back. And the outlook is very good. The prognosis is very good for these adenomas. Sometimes the surgery is the only treatment. You just can't take them all out. And sometimes after the surgery, you need to radiate them so that the residual or whatever you left behind, because maybe it was attached to your optic nerve, so it could not be removed, you want to make sure that that residual stays small, does not grow back. Now, when the tumor is tiny, you often also have to go and take it out. But in addition to actually removing the tumor so that the MRI doesn't show the tumor anymore, well, you also have to make sure that the hormones respond to that. So you have to follow up and make sure that all these excess hormones gets back to normal. And long term, you have to keep on following both the size of the tumor, the MRI, as well as the hormonal profile. And that's where Dr. Sevilla would continue to follow you.
All right, thank you. So next question we had, it was about treatment options. Of course, Dr. Agazzi, we know you come into play with the surgery, but what are the typical treatment options for a pituitary adenoma? You know, you talk about surgery, medication, other approaches, and what factors maybe determine the best choice, Dr. Sevilla?
Yeah, regarding medical therapy, because Dr. Agazzi, he mentioned about surgery, radiation. It's very important that our patients, they know that not all the pituitary adenomas, they require surgery. For example, one of the most common pituitary adenomas is the prolactinoma. They represent around like 40% of the cases that we see. And these adenomas, they produce an excess amount of prolactin. But unfortunately, the majority of them, they can be treated with medical therapy. And the goal in this case for the medical treatment is to lower the prolactin levels, to improve symptoms, and also to shrink the adenoma. 90% of the patients that they have prolactinomas, they have a pretty good response just with medical therapy. Then we have other adenomas, for example, the adenomas that they secrete excess of growth hormone, and we call this disease acromegaly, or Cushing disease, that these adenomas, they secrete excess of ACTH. And surgery, we know that is usually the first choice, if possible. But then if surgery doesn't completely resolve the problem or the patient is not a good surgical candidate, then medications are used to control hormone levels and also the symptoms that the patients can have.
Okay, thank you for explaining that facet of it. And then going back to Dr. Agazzi for the surgical part of it, Dr. Agazzi, can you tell us about the surgical and radiation options if that's the best path?
Yes, so as you can tell, the decision of how to treat an adenoma is really a multidisciplinary decision. Dr. Sevilla and I are constantly talking and reviewing every single case of adenoma to decide what should we do as the only treatment, what should we do as the first treatment, as the second treatment. So whenever medications cannot control either the hormones or the size of the tumor, well, then we have to go in and do it manually, so take it out. And that is called the endoscopic transsphenoidal surgery. So during that surgery, it's an inpatient procedure. You're under general anesthesia, and using cameras that go through your nostrils, we can make our way all the way back to the base of your brain and carefully remove the tumor while preserving the gland. So that is the endoscopic transsphenoidal surgery. Now, sometimes instead of choosing an endoscopic surgery, or maybe after the endoscopic surgery, we determine that additional treatment is needed, and that is called radiosurgery. So as you can tell, it's a name with two terms, radio and surgery. Why is this? Because it's a radiation treatment, so it's non-invasive. You don't even get undressed. It's done in our outpatient center, but it is as precise as a surgical knife. As a matter of fact, our radiosurgery machine is called the cyber knife. So it's a very, very precise way to only deliver the radiation to the adenoma without touching, without damaging anything around it, and that can also help control the size or the symptoms caused by the adenoma.
Wow. I mean, the technology is just so advanced, and it just sounds like it's a multifaceted approach, and there's a lot of options, which is encouraging. All right, our next pre-submitted question. They were wondering, supposing I undergo treatment for pituitary adenoma, what is the likelihood that my energy levels and overall well-being will improve? Dr. Sevilla.
That is a really good question. Why? Because most patients who undergo treatment of pituitary adenoma, they experience improvement in energy, in mood, and overall well-being, particularly if the adenoma was affecting hormone levels. However, the degree of improvement can vary depending on the type of the adenoma, the treatment that is used, and whether any hormone deficiencies remain. In addition, it's very important the regular follow-up with your endocrinologist, so then they can adjust hormone therapy as needed. As well, also, they can support your recovery.
All right. We have some activity in the chat, so I want to pop over to that. We have a nice comment from somebody in the chat that just said Dr. Agazzi is the best. So little shout out there. And then we have a first question, and I'll use this opportunity to remind people, if you are watching live, please feel free to put a question in the chat. We'd love to get to those. All right, so the question is, somebody had a 2.1 centimeter removed, and they want to know, will it come back? I'm sure there's a lot of facets to this, but if one of you wants to address that, if you're able to, the likelihood of something coming back after surgery.
Well, that's a good question, because I would also like to know whether it's going to come back or not. Sometimes it's a little bit different to know until maybe 5 years later. Why? Because believe it or not, when I showed you that picture of that big adenoma, the adenoma is white and the gland is also white. So if you look at the top picture, the adenoma is white and the gland, which we don't see there, is also white. You see the gland in the bottom picture. Both of them are white. So determining after the surgery whether the adenoma is 100% gone can be a little bit tricky. Now, if the adenoma is 100% gone, theoretically, it doesn't come back. But because it is very difficult to know whether maybe a few cells have been left there, we usually recommend a fairly long-term follow-up. Now, it's not very often. We often just do an MRI every year for the first maybe 3 years, and then an MRI every 2 years for about 2 or 3 cycles. And by then, we're like 10 years later. If nothing has changed, meaning that little white spot in the gland has not changed for the past 10 years, then you can tell you, okay, that's all. So it's pretty rare that adenomas come back, but to be absolutely certain, we need to give ourselves some time, several years, to confirm that.
Yep, that makes sense. Thank you for fielding that live question. We have another one. Dr. Sevilla, this one's going to be in your wheelhouse. This person said that they have prolactinoma and they're on medication. Could this condition affect other hormones?
Yes. And when we have a prolactinoma, that as I mentioned, we have an excess of prolactin, and the first therapy is going to be medical therapy. But then, as Dr. Agazzi mentioned, size matters. So what that means is that sometimes we have patients with prolactinomas that they are very large adenomas, and then they can affect the production of the other pituitary hormones. So the first thing that we do when we are evaluating a patient with a prolactinoma is that also we check the other hormones that we showed in the first, in one of the first image. So we evaluate the other hormones, so making sure there's no any deficiency. Something that also is important regarding the prolactinomas is that in, for example, young females, they seek for evaluation more rapidly than male patients. Why? Because then they have irregular periods, so then they go and seek for help for evaluation. And usually female patients, the adenomas, the size is a little bit smaller than male patients. So usually we see male patients with prolactinoma that the adenomas are larger, and then they can be more at risk to have other pituitary hormone deficiencies.
So you're telling us that women listen to their body more than men.
That is correct.
Okay, so quick follow-up. I think that there wanted to be, this person wants a little bit more clarification as like, what is considered large? You all both have mentioned, you know, size matters. What are some of maybe the specs are like large? So
the answer is radiologically. So your radiologist, if the adenoma is bigger than 10 millimeters, that is 1 centimeter, is going to dictate that as a macro adenoma, meaning a large adenoma. Anything below 10 millimeters is going to be a micro, so a small adenoma. So that's radiographically. So if you read the report of your MRI, macro greater than 1 centimeter, micro less than 1 centimeter. But then after that, it all depends on what kind of symptoms you have. So sometimes patients come to see us with an adenoma that is 1.2, 1.3 centimeters, so 13 millimeters is barely above the limit, but it's still not touching the optic nerve, not causing any visual field problem, not really causing any problem. And so we don't necessarily have to treat it. We can just watch it and follow it up to make sure it doesn't get any bigger.
Okay, perfect. Thank you all for the comments and the questions in the chat. If anybody else has any more, feel free to add them. But we're going to continue the discussion with some of our pre-submitted questions that we have. Okay, next question. How do doctors monitor pituitary adenomas over time? And what does a follow-up MRI usually indicate about stability or progression? Dr. Agazzi.
So how do we monitor pituitary adenomas over time? Well, there is two factors, once again. One is the size of the adenoma. The other one is the hormone. So both of them need to be followed up very carefully. The size is followed up with MRIs. We usually do an MRI first after 3 months after surgery or after diagnosis to make sure nothing crazy happens. And after that, once a year, we get an MRI to make sure that the size of the adenoma or the size of the residual stays put, does not change. But again, because the gland secretes the hormones, we also need to follow the hormones. And how do we follow the hormones, Dr. Sevilla?
It's very important to know that when we have a patient after surgery, we follow those patients very closely. So during the first week after surgery, we check some laboratories. We make sure that the thyroid is looking okay, that the cortisol is looking okay. One of the problems that we can see is problems with water balance because one of the hormones that it's stored in the posterior pituitary gland, the ADH, can be affected. So also we check sodium level, urine, plasma osmolarity. Then we check again the pituitary hormones 6 to 8 weeks after the surgery, and then 3 months after the surgery. And then if everything is stable, then like we can start to see the patient less often. But follow-up, it's very important, and is what is going to make a difference with these patients.
Yeah, that sounds very big part of the journey there. Okay, let's talk a little bit more about the hormone aspect of this, Dr. Sevilla. So we have a question about growth hormone suppression tests. So can you explain what that test is, and then how is that used to make the diagnosis?
Yes, for sure. The growth hormone suppression test is a tool that we use to help confirm acromegaly when the diagnosis is not completely clear. So it's important to mention that the IGF-1 is our best test to check for excess of growth hormone. Why? Because it's related to the growth hormone levels and stays steady throughout the day. Since the growth hormone fluctuates during the day, IGF-1 can give us a better picture of your overall growth hormone activity. If the IGF-1 is clearly high and you have signs of acromegaly, then we often don't need further testing, and then we can go and order a pituitary MRI. But then if the results are borderline, then we can do a growth hormone suppression test, where you are going to drink a sugary solution to see whether your growth hormone drops the way it should.
All right. So another question we had that was pre-submitted. What symptoms should patients watch for? I know you all have talked about these follow-up visits and sort of staying on top of the journey afterwards. What should patients watch for between follow-up visits that might indicate changes in the adenoma behavior, or if the adenoma is coming back, Dr. Agazzi?
Well, once again, size and hormones. In terms of the size, don't worry. You cannot feel your you cannot feel your adenoma growing. It's just not possible. Those adenomas, they grow extremely, extremely slowly. So the follow-up MRI that your physician recommends, either once a year, once every 2 years, once every 6 months, is going to pick up any change in that adenoma size way before you can pick up any change. Now, at the same time, the hormones can change. And Dr. Sevilla, what can people experience?
Yeah, some people, they can report weight changes, fatigue or weakness, mood or sleep disturbances. In females, irregular periods or fertility issues. Males can report changes in libido, increased thirst or urination. And when we have patients that they have pituitary adenomas that are secreting excess of, for example, growth hormone, patients can see enlarged hands, feet, or changes on the facial feature, also uncontrolled diabetes or high blood pressure, or sometimes they can have problems with their bones, and they can be at risk to have vertebral fractures. With Cushing disease, patients can report unexplained weight gain, easy bruising, purple stretch marks, also like the diabetes was well controlled and now the numbers are getting high, or the blood pressure also is going high. So all these are clues that can guide us toward the correct diagnosis and the further workup that we are going to order.
Yeah, and all those are important to know because it's like you want to be in tune with your body and any changes, so you can just be on alert for these things. We did have a comment in the chat, another person singing your praises, Dr. Agazzi. They said they could not ask for a better surgeon. You are awesome.
Thank you very much. Thank you.
You're welcome. Just passing along the note. Okay, another pre-submitted question about hormones. Can you tell us what changes in hormone levels patients should be aware of that might indicate changes in the adenoma? I know you sort of touched on this, Dr. Sevilla, but if you could maybe expand on that part of it.
Yeah, usually we like to evaluate those patients and continue monitoring the hormones for that reason, right? And sometimes it depends on the type of the adenoma, but then I'm gonna put an example for prolactinomas. We are treating the patients with medical therapy, and we are monitoring the prolactin levels, but then the prolactin levels start to go up, right? So that can be a sign that then we have to adjust the medical therapy. And if then later on we don't see that we are having a good response with the medical therapy, then usually I discuss the case with Dr. Agazzi, and in some cases we can consider surgery for those cases. So it depends on the type of the adenoma. really like to go over on all those lab results for the patient and then explain like step by step, like what we are seeing, right? And then how we can then adjust the medical therapy depending of our goals, so then the patient can feel better and we can see also like better numbers.
I think I hear a lot of questions about concern about what happens in between, what should I need to be aware of after my treatment. I would insist that if the care that you're getting for your pituitary adenoma is done in a center that has a comprehensive management, where there is neurosurgeons, but also endocrinologists that are dedicated to the pituitary gland, you don't have to worry about you picking up some changes, because the way that the follow-up is organized, whether it is the frequency of the MRIs every 3 months, every year, every 2 years, is designed so that the MRI is going to pick up any changes before it's too late. And in the same way, Dr. Sevilla might ask for hormonal checks every week after the surgery, and then every year once you are 2 or 3 years after the surgery. Now, those intervals are very carefully determined depending on your situation. And so that degree of expertise puts the burden on those lab tests to tell us what's happening to you, so that you don't have to worry about always being on the lookout. Am I okay? Is something happening? Because we will take care of that for you.
Yes, very important to point that out, that it's just very specialized care in each individual situation. One last note to see if anybody else has any questions or comments they would like to put in the chat as we are winding down here. And then Dr. Sevilla, Dr. Agazzi, if there's anything else that you would like to add, I always like to give an opportunity if there's anything else that you wanted to add on to this discussion. I feel like it was pretty well-rounded though. I feel like we covered a lot of ground here.
Well, no, thank you very much. And again, I cannot highlight how much the role of Dr. Sevilla is in this workup, because all the things that she said about these hormones and all this hormonal workup can be very daunting. And when patients come to see us and bring some hormonal workup that has already been done, we often have to complete it. We want to repeat it, not because we don't trust other people, but it's because determining the exact situation of your hormones before diagnosis, after the treatment, during the treatment, has such an incredible impact on the overall outcome. And so having a very careful analysis, doing all the tests that we ask before the treatment start, is not because we want to procrastinate or delay the treatment. It's only because it's important to understand the disease extremely well so that we can recommend the best treatment and finally hope for the best outcomes.
Wonderful. Did you have something else to say, Dr.?
Yes, and it's just like a very short
yes,
information that I think that what it makes also like a big difference, as Dr. Agazzi mentioned, is, like to have a great multidisciplinarity. And this is what we have here at USF Tampa General. These patients, sometimes they have been seen by an endocrinologist, local endocrinologist, or an ophthalmologist, and then they send it to us. And then some of them, they see endocrinology, they see neurosurgery, but then they require other specialties. And then in our program, we have like all the specialties that these patients sometimes can need. And we have like a great communication that I think that makes the difference, right? Like, because then we are available for each other, and then we want the best for the patients. And I think that make a big difference.
I think that's wonderful. And it's like obvious that you two have a great rapport, and that communication is essential. Okay, before we close it out, we do have one person who got in a question here. If y'all wouldn't mind answering this before we close things up. You've talked about a lot of things to like be aware of, maybe for like a reoccurrence. This person wants to know, is there anything you can do to prevent a reoccurrence? Whichever one of you wants to field that one, or both of you.
Well, preventing a reoccurrence usually means that either the tumor is completely cured, so it's gone from your body, or it requires some additional treatment. I would say that to prevent a reoccurrence, you have to follow up with whatever additional treatment was recommended to you. Whether it's a medication, you have to stay on that medication, otherwise the tumor is going to come back. If it was radiosurgery, well, got to complete that radiosurgery, otherwise the tumor is going to come back. and any other treatment that was recommended. And usually tumors behave well when they are treated completely, all the way from the beginning to the end of the treatment.
And many of these patients, they need long-term follow-up, like our patients with Cushing disease, our patients with acromegaly. So I think that that makes the difference in terms of decreasing the risk for recurrence, right? Or if it happened, then we can catch it early.
Wonderful. Well, thank you both so much, Dr. Agazzi and Dr. Sevilla, so much just for your wisdom. And I think it's really important to have the different facets of the care team to speak on the different nuances in care for patients. So thank you also to everybody else who joined. We had wonderful questions, pre-submitted and live ones. Want to make a quick note, this dynamic duo, we are doing another stream again with Dr. Agazzi and Dr. Sevilla, Understanding Pituitary Adenomas in Spanish. So if you or someone you know would like to watch that one, that's going to be on Thursday, January 15th from 12:30 to 1. So we look forward to having you all back again in Spanish next time. If you want to know more about our pituitary program, please visit the web address on your screen or scan the QR code to take you there. Thank you again for watching and have a great rest of your day.